So let's come to another aspect, the intraoperative and traumatic malposition of the lenses. I'll straightway go to small videos. I think, yeah, okay, fine. So this is around 20-year-old video I'm just showing, 15-year-old probably. So intraoperative zonular dehiscence. As you can see that the quality of the video is not that good, but this is the capsulorhexis. Those days we are hardly using any trypan blue. This is something a 99 or 2000 video. This stands as a hallmark from where I changed over a lot of surgical procedures. Now this is a soft cataract. Those are the days as you are going periphery, trying to do chip and flip, going still towards periphery, and then trying to do that cartwheel technique, which early and we tried to do it. And then when I was not getting a hold, that's very important. If you have a small rhexis, this would happen. So the whole I had caught the rhexis margin and gone forward. And then again I thought I'll do it. I was not that experienced well. And then again the whole thing, I thought that it is almost 90 degrees subluxation now. I have to do something about it. I used a viscoelastic just to lollipop that cortical matter out. And there use CTR injector. Those days we had a CTR injector with us. Unfortunately, we don't have one now. And the CTR, once the CTR goes in, and so the bag is again the surgical procedure is just like any other procedure that we have done the surgery, and then removing. Those days I used to use the coaxial IA, and you can see gradually get the whole thing, and the surgery becomes well, and put the lens of my choice. Change. I think the second one. Yeah. This is a traumatic cataract again. I would come to this. So this is very difficult to maneuver it when you are not doing it with your own laptop and all. Now this is a traumatic cataract. This has got a 90-degree subluxation. This is a trauma, so I'm aware that I'm not using any hooks or anything, but then it looked, the iris looked picked. So I should have done put in some triamcinolone to check if the vitreous was there, but in the slit lamp definitely I could see some strands of vitreous. So in these cases, actually just putting a CTR does the job. As I said, the basic principle, if it is less than 90 degree, and just put in the CTR, go ahead with the emulsification, and then you can feel I could feel the iris picking out, and a lot of strands coming there. So towards the end of the surgery, just take her out the cortical matter. As you can see, just sideways. As I said, if you put the CTR early in the procedure, it may be a bit of difficult, but if you do it quite often, you can actually manage it. I could have put the CTR at the end of the surgery in this case, but since I was aware that there is a bit of vitreous there, and see the iris is picked up, it's very important that I remove this vitreous. As I can see, swipe it with the hook, and there putting in actually delineates all the vitreous there, and then doing a good vitrectomy. As you can see, once I do that vitrectomy, the whole lens would move forward and the pupil become round, and that would end the surgery. Next, changing over is I think this is this is next one. Yeah, this is again around less than this is 26. This is just more than 180 degree. You can see I put a rhexis marker there and do a bit vitrectomy. This is again a traumatic cataract. I can see the lens is tilted. Do a vitrectomy right, and there's, as was said earlier, it's very important where do you center your rhexis. As you can see, I have made the rhexis a bit away from the subluxated side so that I can get the rexis actually the lens, centering the lens, as you could see. And this stage it is little more than 90 degree and less than 180 degrees. So putting a CTR there would center my lens and the rexis, and then continuing the vitrectomy and then clearing the vitreous there, putting the iris hooks there to hold the capsular margin, and then do with my phacoemulsification. And in these cases normally I would lower my parameters a bit, then I do around 450 or 500, here bring it around 300, do slow motion phaco as you could say, and then doing a bit of irrigation aspiration, and then put in the lens as you can see, and then in this case also continuing with the vitrectomy, and just this without any capsular support, without any scleral support, I could continue this case. And I come to the last case of this series. This was a subluxation quite bigger than I was expecting. This was almost more than 180 degree. I could see the vitreous already. This is a white cataract, as it's a quite old cataract. Fibrosclerosed anterior capsule is very important to get me the right puncture. And once I got the puncture, I could continue the capsulorhexis with the, as Dr. Biswas was saying, it's very important that you use that, because the lens is tilted. Here if I try to go with from the main incision any Uchrata forces, that would, every time the anterior chamber would become shallow. So here from the side port, microrhexis forceps, as you can see, and the staining somehow was less. I tried to use a little less, and then I decide to put the CTR, as is my practice, because I would like to stabilize the lens before I go ahead with the emulsification, as I've done it. So then I realized that there are a lot of vitreous. I put a triamcinolone. As I'm doing vitrectomy, you can see the whole lens is tilting. As more and more vitreous comes out, so it's very, I just on the height side doing a pars plana vitrectomy in these cases would work, because as you try to clear the vitreous, the whole more and more vitreous comes on because you are putting in fluid. And then I realized I put a iris hook, the iris hooks there to hold the rhexis margin, and then continue with the bimanual IOA. As you can see, the tangential movement, if you put the CTR before removing the cortical cleanup, but in these cases, as stated by Partho, put it as and when it is required. And this case, see, a tangential sideway movement can actually get you out the cortical matter. And then once that is done, in this case, since it is more than 180, I just put in the lens of choice in this patient, because I would prefer to use a bigger haptic with a bigger, longer haptic, and then use a supporting device, in this case a CT segment, to support it. I normally don't take out a flap, I just do a scleral small incision, and through that normally I take out the railroad technique, as you have seen in earlier cases. The same way, it's very important when you put this needle so that you don't catch the cornea. This is some small tips that you just put maybe a spatula just to make that space so that the needle goes in, and maneuver it. In the second, when you are trying to put the second needle, it might happen that whole thing might come out, though, and then again maneuver it, take it out from the other side, and then center it gradually. This centering it was important, though it was a traumatic cataract. It is not a progressive one, but in these sort of cases where it's more than 80 or just touching around 80s, you do it and then get it towards periphery, and then maybe do a bit of residual vitrectomy, and that would end your case. Thank you. With this, I come to the end.